Three, two, one. We are live now.
Oh, wait, hold on. I can't play my presentation. Okay. There's some glitch. I'm not able to play my presentation. Let me see it again. No,
I'm absolutely fine if you want me to start. I'm fine with that.
no, just a minute. I know what's the problem.
Okay.
Uh,
Yeah, we can see your
Got
screen.
it?
But
Wait,
yeah,
hold on, hold on. Okay, can you see? Okay.
yeah, we can see.
Thank
It
you
looks
very much. Sorry for the glitch. I welcome all of you for the second residents and fellows spine training program. This program has been brought to you by Intas, who are the sponsors for this event. They have products that we use very commonly, Gabapin NT, and this has been live streamed on OrthoTV, where it will be available for you to watch it later as well. So we have an interesting program for you today, and I think it's a unique program because I don't think this has been done before, and it's very basic, which includes evaluation of the spine, and the faculty include me, as well as Dr. Uday Pawar, who is a consultant at Global Hospitals. Ayush Sharma, who is a consultant spine surgeon, a minimally invasive spine surgeon from the Railway Hospital. Manish Kothari from Jaslok Hospital, and Dr. Abhilash Dhruv, who is also going to join us today for this program. So let me start because I have to begin this with spine examination, and this is going to be a long talk. So I hope I can finish this on time. We'll try to cover as much as possible, but I have collected some interesting photographs and videos for you to see. So I hope this is interesting for you. So we all know about Sherlock Holmes, right? The most famous detective of all time, solving crimes using these powers of observation and logic and deduction. But most of you probably don't know that Arthur Conan Doyle, who is the author of these books, based the character of Holmes on a real life surgeon called, his name was Joseph Bell. And Dr. Bell was renowned for his extraordinary observational abilities, which he used for treating his patients. And our job as physicians is somewhat similar, and it is essential for us to learn aspects of this detective's art. Diagnosing an illness is often like trying to put together a jigsaw puzzle, with the hitch that you cannot have all the pieces. Some of these are hidden, some of them you have to seek, and others are permanently lost. But you still have to put together this puzzle and look at the whole picture. And you have to do this in a systematic approach like Sherlock Holmes. In our specialty, we first hear the history from the patient, do an examination, look at the imaging, think of a diagnosis, and come up with a plan. But if you jump to conclusions like Dr. Watson in the novels, then you'll make a mistake. And a common situation is looking at the MRI first and then trying to fit the patient's history and examination in a particular diagnosis. And you will make an error that way. So you need to have a systematic approach to this. A doctor who cannot take a good history and a patient who cannot give one are in the danger of giving and receiving bad treatment. So history is definitely the key to the diagnosis. You should have a good understanding of the patient's symptoms and have a working diagnosis in mind before even you begin a spine examination. And you need to acquire some interrogative skills like Sherlock Holmes to become good at this. So the present talk is about that 10%. So I started with this so that you don't forget that the history is the most important thing here. The history also helps you focus on your physical examination. Which region of the spine are you dealing with, whether it is cervical, thoracic, or lumbar? It is practically impossible to examine everything. And secondly, on the basis of the symptom complex, you will be able to direct the examination to a particular region. For example, if the patient has some spine pain, you also have to think of non-spine causes of pain. Arm pain could be shoulder or entrapment syndromes. Leg pain could be from the hip or knee or PVD. Numbness could be peripheral neuropathy and so on. So once you have the symptom complex, you can direct your examination even to non-spinal areas and come up with a diagnosis. In general, spine examination, you can divide it into 8 sections: look, feel, move, neurological examination, some special tests depending on your working diagnosis, other joints, vascular examination, and then finally a general examination. The equipment that you need for a neurological examination is a Taylor's hammer, a 128 hertz tuning fork, a light, some pins for testing pain, cotton for testing light touch, a measuring tape, and a tongue depressor. And I like to use this hammer. This is the Queen square hammer, but it's important to keep a consistent type of reflex hammer because you get habituated with it. What you practice throughout is the something that you keep on using. Scoliometer, again, we treat a lot of deformity. It's imperative for somebody who treats deformity to have a scoliometer with them, because this is the way we judge the rotational component of the deformity. You should also have a plumb line and maybe a ruler. So the first part is look. You have 5 sections, and the initial is gait. And you are most likely to learn about the diagnosis by just watching a patient walk than any other single test that is there in spine examination. It is almost like Sherlock Holmes, if you like, who's watching somebody and then finding out who is the criminal. So you will be able to identify the diagnosis many times if you examine the gait carefully. So these are the different types of gait patterns. We all know the hemiplegic gait pattern, which is very classical. A diplegic gait pattern happens in a spastic gait. Typical example, cerebral palsy. It can happen with chronic spinal cord lesions where there is significant spasticity, and you can get almost scissoring if the adductor spasticity is a lot. Parkinson's gait is a slow shuffling gait. Initially, the patient walks in very short steps, and then they can speed up and tend to fall forward. They have tremors, mask-like faces, rigidity, and this is called as a Festinen gait. And it's important to know all these non-spinal causes of gait patterns as well, which are neurological, because many of our patients might have more than one diagnosis, or for that matter, I've had patients who have Parkinson's disease getting mislabeled as cervical myelopathy because they are not typical features. So sensory gait is like a stomping gait where you have peripheral neuropathy and the patient stomps their feet to understand where the ground is, so that because they cannot feel their joints position, so they tend to stomp their legs very forcefully to walk. And then you have these ataxic gait patterns seen in cerebral dysfunction or posterior column dysfunctions, including thoracic spinal cord compressions or cervical spinal cord compression. We call this myelopathic gait. But truly, myelopathic gait is a combination of ataxia as well as spasticity. But you will see that they have this staggered quality, wide base gait. You will confuse them with an alcoholic patient. An alcoholic patient would walk exactly something like this. A patient with cerebellar dysfunction would tend to kind of stagger toward the side of the cerebellar lesion. They'll keep kind of going in one direction to the side of the cerebellar lesion. And more importantly, when you make them stand, they are going to sway. And they are going to sway even with their eyes open, and that is called titubations. Mild ataxia can be revealed with tandem gait pattern like this heel to toe gait. But remember that elderly people, typical ones who have cervical myelopathy, may not be able to do this normally. Like a normal elderly person, because of balance issues, may not be able to do this even if they don't have cervical myelopathy. Neuropathic gait pattern. This is a foot drop patient having a high steppage gait. You can see the hip and knee is flexing. And this is a patient, sorry. Okay, the Trendelenburgs is missing. Okay, it will come later. So this is a patient with some dorsiflexion weakness of the ankle, where it's not very apparent on walking, but you can reveal it by asking the patient to do a heel walk. You can see on the right side, the patient is not able to do a heel walk very well. Is not able to dorsiflex the ankle. The seventh gait pattern is myopathic pattern seen in muscular weakness of the pelvic girdle. This patient actually is neuropathic pattern because the patient has a neurological nerve compression at L5 and a gluteus medius weakness. And this is a Trendelenburg's gait pattern where the patient waddles on the side like this. And you will be able to see that he also has a Trendelenburg side sign positive. When the patient stands on the normal side, you can see the pelvis is level, but when you make the patient stand on the abnormal side, then the sound side sags. So that's an easy way to remember the sound side sags. So that's normal. And then this is abnormal. You see the pelvis is sagging on the left side. So we'll skip this. Then Romberg's test, one common misconception is that this is a cerebellar sign, but this is not a cerebellar sign. This is again examination of posterior column dysfunction and severe peripheral neuropathy. With cerebellar dysfunction, lesions of the cerebellum, patient will have titubations, which means patient's eyes are open and the patient is still swaying. Here, cerebellum is the main central processing unit, and to maintain balance, it gets input from the eyes, the inner ear, as well as the peripheral system, the posterior columns and the peripheral nervous system. So in diseases of the peripheral nervous system as well as posterior column, the cerebellum is relying on the eyes or the ear. And it can function quite well if two of them are present. But if you ask the patient to close the eyes, then the only input the cerebellum is getting is from the ear, and that is not enough. And that's why the patient sways. So that's the mechanism. Posture of a normal person is erect. You know what an erect posture is. These are abnormalities of posture. This is angstpond with kyphosis. The other patient has cervical kyphosis. This is abnormalities of posture because of severe scoliosis. You can see the shoulders are not level. There is a flank crease. The rib is prominent on the right side. The pelvis is not level. Pelvis is tilted. Left side is up. And that's why there is an apparent limb length discrepancy. And that's why the patient is standing with an equinus. So this whole gamut of changes in posture is happening because of severe scoliosis. This patient has a different kind of scoliosis. Is an adult deformity, degenerative scoliosis with an imbalance in posture. This patient is not an adult deformity, but camptocormia that is seen in Parkinson's disease. It's completely correctable when you make the patient lie down like this. This is a painful posture of disc herniation called sciatic list, which is a uniplanar shift of the trunk. There is no rotational deformity. And if you make this patient lie down, the deformity is going to disappear. This posture is of a patient with lumbar canal stenosis. They tend to stand with a slightly forward flex posture because it relieves the pain of canal stenosis, also called as simian stance. This is a typical Fallon-Dixon sign of a high-grade spondylolisthesis patient. You can see this patient is standing with knee flexion and equinus. Actually, the patient is walking with an equinus deformity. This patient went on and got such a extensive neuropathy workup, and they got EMGs and this and that. And this patient actually was a classical Fallon-Dixon sign. And if you see it, the whole thing points to hamstring tightness because of the high-grade spondylolisthesis that this patient had. This is a patient with abnormalities of postures of the neck because of torticollis, because of a craniovertebral anomaly. This patient has craniovertebral tuberculosis and then having a posture like this where she's cradling her head in her hands because she has so much pain. Then coming to alignment. Alignment is easy. Spine is straight in the coronal plane and it has four curves in the sagittal plane. We all know that. Abnormalities in the coronal plane would be scoliosis, and in this talk cannot cover description of scoliosis, but If you have a patient with scoliosis, then there is a way to describe a scoliosis, and that would be a coronal plane abnormality. Adams forward bending test is a quick test to kind of screen patients for scoliosis, because rotational component of that deformity is quickly seen even in small degrees of scoliosis. In sagittal plane, thoracic spine is normally kyphosis. So if you have abnormalities, if you have hypokyphosis in adolescent idiopathic scoliosis, it will look like this. Or in extreme congenital deformities, you can even have lordosis in the thoracic spine. This patient has thoracic hyperkyphosis. Kyphosis would be something that is normal in the thoracic spine, but this is hyperkyphosis, and this is very angular, typical of spinal tuberculosis. And this is very round kyphosis, typical of Schurman's kyphosis. A very small prominence of the spinous process would be called as a knuckle, because it looks like the knuckle of your hand, and that would be just collapse of one vertebra. In the lumbar spine, normally lumbar spine is lordosis. In painful situations, you will find loss of lumbar lordosis. In extreme situations, you will have hyperlordosis in this, like this patient on the left who has cerebral palsy, hip flexion deformity, and that's why the patient has a very large lordosis in the lumbar spine. This patient has a degenerative scoliosis along with fractures, and that's why there is lumbar kyphosis. Also look at the skin, because there will be a lot of abnormalities. Sometimes you will be able to see, and then you need to adequately undress the patient to see the area. So don't forget that this patient had a fungating sarcoma right on the sacrum with back pain. Then also look at, sometimes there are cold abscesses, even presenting at distant sites from the spine, tracking along the ribs or into the thigh from the spine in tuberculosis. The next section is feel. You are feeling for the local warmth, tenderness, bony palpation, soft tissue palpation. Superficial tenderness generally not present unless you have something right underneath the skin like an abscess. So if somebody is complaining of severe pain on you just light touch, it generally means overreaction, or the patient is exaggerating their pain. This is the way you check deep tenderness. Take a fist and thumb on the back, and that, if the patient has pain, generally means an anterior column pathology or a disease. Bony palpation, palpate for the spinous process. You can palpate for steps sometimes in spondylolisthesis, or gaps in the spinous process and fractures or crepitus. Also palpate for the coccyx. Sometimes they have pain in the coccygeal region. You can palpate for the other bony prominences, including the greater trochanter, because you'll be surprised how many people who complain of leg pain have greater trochanteric bursitis that is radiating down the side of the leg. They actually don't have radiculopathy, but they have greater trochanteric bursitis. It's very easy to confuse it with. And sometimes patients have two problems. You have lumbar canal stenosis, listhesis, as well as greater trochanteric bursitis. So make sure you're palpating greater trochanter, ischial tuberosity. Ischial tuberosity bursitis is like pain going down the hamstrings. It sounds very much like sciatica. So make sure you do bony palpation, soft tissue palpations of the paraspinal muscles. Sometimes there is a spasm like this, and you will feel them hard and firm. The deep midline groove becomes prominent when there is a paraspinal muscle spasm. And don't forget to palpate other soft tissues around the spine, kidneys, wherever there is where there is relevant, and you find there is renal angle tenderness, etc. Remember the location of the pain or the deformity with respect to the surface landmarks. We all know that, and I'll not go into that. Then comes move. So only active range of motion is tested usually, and you are not testing range of motion if you suspect trauma, fractures, suspect instability, or if the patient has neurological deficit, because it has very little to value to add. You would describe pain movements mostly as normal or restricted, with or without pain. And sometimes you might describe the rhythm as well, whether the motion is halting or has an aberrant pattern. Range of motion of the cervical spine, flexion and extension, most of it happens at OC1, and rotations would happen at C1, C2. A normal person would be able to look at the ceiling and look at the floor, and maybe 80 degrees on either side. Lumbar spine flexion, it's very variable. Some people are able to touch the floor, some people are not. This flexion movement is happening not only in the spine but also in the hips. If you want to isolate just the spine, then you'll have to do a modified Schober's test. But in general, we are doing a screening thing by just asking the patient to bend forward. If the patient has pain in this movement, generally indicates an anterior column problem. Typical patients with pain originating in the disc or discogenic pain would have a flexion intolerance, which means that they will feel more pain in positions which are flexed or flexed and loaded, or sitting position. Like if you get a history of prolonged sitting and having back pain, that's a discogenic back pain, because sitting is a flexed lumbar spine position. Then ask the patient to lean backwards. Extension usually is limited, but facet joint arthritis pain may cause an extension catch or pain. Even pars fractures or irritations of the pars lesions would cause pain in spinal extension. And when the patient is coming from flex position to extension position, observe the way the patient is moving. This is a typical pictures of a reversal of spinal rhythm, which you will find sometimes who have patients who have instability. They tend to flex their knee and hips before they bring their spine backwards. They are trying to tuck their pelvis inwards before they bring the spine backwards, just to reduce the amount of pain that they would feel because of spinal instability. Again, extension catch is something that you might notice when the patient comes back. If you suspect pars lesions or SI joint lesions, they can get exacerbated in this single leg stance extension test, also called as the Stork test. Not very sensitive, but you can pick up sometimes lesions in the posterior column with these kind of tests. Then coming to neurological examination, higher mental function, you don't need to do this because most patients who come to the orthopedic OPD, they are giving a clear, coherent history. If your patient is not mentally sound, and probably should not be in the orthopedic OPD in the first place, they have a other bigger problem to deal with. But cranial nerve examination, yes, please do cranial nerve examination. There is, depending on the syndrome and the clinical history the patient is presenting it with and what you are suspecting. Because let's say a patient has features of myelopathy, how do you differentiate that from say multiple sclerosis? Multiple sclerosis patients can have eye pain, optic nerve involvement, craniovertebral problems can have nystagmus. I think somebody's microphone is on, so it's kind of disturbing. So I'll request everyone to switch off their microphones. Observe eye movement. The nystagmus can be there in high craniocervical lesions. But most importantly, compressive lesions at the craniovertebral area can involve the lower cranial nerves. So you should know how to examine the 9, 10, 11, and 12 at least. So this is a patient with basilar invagination and high cervical spinal cord compression. You see, I'm poking the back of the throat with a Q-tip, and the patient is not gagging. So this is the gag reflex, and this would be absent in the glossopharyngeal and vagus nerve if they are involved in high cervical level lesions. And this other is a hypoglossal nerve involvement, where when you ask the patient to put out the tongue, it deviates to the side of the lesion. That's again a hypoglossal nerve palsy. So this is something that you should probably look for. Uh, Coming to motor examination, important thing to remember is that you need to do this in this sequence. Always check for the tone and the deep tendon reflexes first, because they are altered by pain and anxiety, and then do the others. Look for muscle wasting. This patient has deltoid wasting. This patient has hand wasting. This patient had cervical myelopathy. The thing with hand wasting is we always associate wasting with lower motor neuron lesions, but hand wasting in cervical myelopathy doesn't necessarily mean that this patient has a C8T1 lower motor neuron lesion. The hand wasting you see in cervical myelopathy is a false localizing sign. False localizing means it's falsely localizing to the C8T1 when actually the lesion is at higher level. We don't exactly know what is the mechanism by which this happens, but remember that having wasted hands in patients with cervical myelopathy doesn't necessarily mean it's lower motor neuron in the intrinsic muscles at the hand at C8T1. You can measure wasting. This is an interesting patient who came to our OPD with a reference for surgery for a L4, L5 disc herniation and left-sided severe leg pain. And when we examined this patient's left leg appeared a little smaller and wasted. So you can see how you measure, take it from a fixed point from the joint line in the flexed position. In the flex position, you can check the joint line very clearly. And then at a fixed point, you measure the circumference of the calf as well as the circumference of the thigh. And in this patient, we found that the left side thigh was wasted, calf was also wasted, and it was not fitting with the L4, L5 disc herniation. This patient actually had a lumbar plexopathy and eventually ended up getting admitted and getting IV immunoglobulin, and that disc herniation was just a red herring, right? This another red herring. This patient came with an L5S1 ischemic spondylolisthesis, referred for surgery. Patient had been told about surgery, but this patient had significant wasting in the lower extremities, more distal than proximal. Hands were normal. And on asking the history, the patient said that his mother also had the same problem. Bilateral L4, L5, and S1 were zero in this patient. His mother had the same problem. His grandmother had the same problem. This was in hereditary polyneuropathy and typical inverted champagne bottle appearance of hereditary polyneuropathy. But the surprising thing is that this patient was advised surgery for an adult ischemic spondylolisthesis at L5S1. So all those things are important in your examination. So this patient has fasciculations. Again, patient presenting with cervical myelopathy kind of features, spastic gait, brisk reflexes, no sensory symptoms, but on close examination has fasciculations in the arm. I'm not sure whether you are able to see the fasciculations on the video, but there are, if you look carefully, there are tongue fasciculations, and then later probing the history, the patient says they have dysarthria also. And then this diagnosis becomes motor neuron disease, right? This is no longer cervical myelopathy at all. Inspect for deformity contractures, because these intrinsic minus hands and claw toes and all might indicate a motor problem coming from the spinal cord. Hypertonia, spasticity in the legs. This is how you examine it. Roll the leg so that the patient is relaxed and then suddenly flex the knee. The ankle should, the heel should stay on the bed, but you can see in this patient, the heel is going up. Remember that spasticity is velocity dependent. And that's why the more fast you do this, the more the muscle will contract because the stretch reflex get activated. And this is a typical example how you would judge spasticity in the lower extremity. This patient has clonus. You gently dorsiflex the ankle and you'll say sustained clonus. This is never normal. You cannot have a normal person having clonus. This is always corticospinal tract involvement, 100% specific for an abnormality. Tone in the upper extremity is just this way. You shake the person's hand and supinate and pronate gradually, as well as flex and extend. Vary the speed as you do this, because again, velocity dependent, it is spasticity. If it is not velocity dependent, then it is rigidity, which is a sign of extrapyramidal spinal involvement. Muscle stretch reflex are also known as deep tendon reflex, but the right terminology is a stretch reflex in the lower extremity. Knee is L4, ankle is S1. You all know how to do this. Grading of reflexes, I'll skip. This is biceps reflex, localizes to C5 and C6, predominantly C6. You put your finger on the biceps tendon. You see here the elbow is flexing. Then this is the brachioradialis reflex. If when you hit the the styloid process, a normal contraction would be just the contraction of the brachioradialis. But in this patient, you can see three responses. The brachioradialis is contracting. The biceps is also contracting because you can see the elbow flexing every time I am doing the reflex. And also the fingers are flexing, and that is happening because the afference is spreading to other spinal levels as well, above and below. And his all the segments C5, C6, and C8, sorry, C6, C7, and C8 are all upper motor neuron, and that's why they are exaggerated. Now you see this patient has, when you do it, you will see that the fingers are flexing, but I can feel the tendon of the biceps that is not contracting, and the brachioradialis is also not contracting. A lot of people miss this. They would call this reflex, the one that we are seeing here, as the inverted supinator reflex. But this is not an inverted supinator reflex. This is a brisk reflex, and it is brisk. Everything is spreading away. This is an inverted supinator reflex where you are not getting brachioradialis contraction, you are not getting biceps contraction, but you are getting the finger jerk positive because the reflex is spreading to the lower levels. And this is a very specific reflex. The specificity of this is almost 90% plus, and it localizes to lower motor neuron C6 and upper motor neuron below. So it localizes to C5, C6 level or C4, C5 level. This is a triceps reflex. Root value is C7. This is a brisk triceps reflex. And then you can check all the three reflexes, biceps, brachioradialis, and triceps in the sitting posture also by cradling the arm like this. This is the finger flexion reflex C8. You put your fingers there like that and then tap it. You will feel the contraction of the fingers. Hoffman sign, it's always misconstrued as a Babinski of the upper extremity, but this is just a muscle stretch reflex. And the same way a normal person can have brisk knee jerk, the same way a normal person can have a Hoffman sign positive. This is not a pathological response. An exaggerated Hoffman sign just means that the muscle stretch reflex is exaggerated. It localizes to C8T1. The usefulness is a bit controversial because the sensitivity and specificity is all over the place in literature. Remember that it can be present in normal people, but a unilateral Hoffman's or a bilateral Hoffman's with other signs positive may be a sign of myelopathy. Now, this is a Tromner sign where you are flicking the volar aspect of the middle finger rather than the other way around in Hoffman's. And this is more specific and sensitive compared to Hoffman's. It is useful for both ruling in and ruling out of myelopathy. The root value again is C8T1, and all lesions that are above this C8T1 would have this reflex positive. Now the reflex on the left side is the deltoid reflex, localizes to C5, and the reflex on the right side is the scapulohumeral reflex, localizes to the craniovertebral junction. So in the deltoid reflex, you are tapping just beneath the acromion and the arm is abducting. And in the scapulohumeral reflex, you are downward tapping the acromion, and what you are looking is the elevation of the scapula. The upper part of the tricep trapezius muscle is contracting and the scapula is elevating. So the localization is something that you need to remember. The brainstem is a jaw jerk. So if all your reflexes are exaggerated, then you are going to check the jaw jerk. And if jaw jerk is positive, then your lesion is in the brain. If it is scapulohumeral reflex is hyperactive, then lesion is craniovertebral. Deltoid is C5, C6, mostly C5. Sorry, deltoid reflex is C5. Biceps is C5, C6, but mostly C6. Triceps is C7, and Hoffman's and Tromner's is C8T1. So the way to remember this is like this. If your knee jerk is normal or hypoactive, then it is either not cervical myelopathy or the patient has tandem stenosis or some lumbar spine lesion that is making the knee reflex hypoactive. If your knee jerk is hyperactive, look at the Hoffman's or the Tromner's. If the Tromner's is normal or hypo, the patient may have myelopathy. The lesion may be lower motor neuron at the cervicothoracic junction because localization of Tromner's is C8T1. If Hoffman's is hyperactive, this is potentially going above the C8T1 level. And if you have scapulohumeral reflex hyperactive, deltoid reflex hyperactive, then it is a high cervical lesion. If it is a biceps, it is C6 localization, which I'll show you here. This patient has suprascapular reflex negative, deltoid negative, but brisk C6, C7, and C8. The lesion is at C3, C4 disc level, which is where the alpha motor neurons of C5 will lie. So this will be lower motor neuron C5 and upper motor neuron C6 and C7 and C8. So everything C6, C7, C8 reflexes are exaggerated. So next, this patient has biceps not contracting, inverted supinator reflex positive, triceps hyperactive, finger jerk hyperactive, Tromner's hyperactive. So this lesion localizes to C4, C5, which is the disc herniation where alpha motor neuron is C6. Remember that spinal cord is shorter than the spine, so it will be one level shorter. So at C4, C5 disc level, the spinal cord is C6, and that's why C6 reflexes will be hypoactive. C7, C8, T1 reflexes will be hyperactive. This patient has hyperactive everything, but jaw jerk is negative. So things localizes to the craniovertebral area, has basilar invagination. Then coming to Babinski, upgoing planters, fanning of the great toes. This is an Oppenheim sign. Sometimes you can get that as well. Abdominal reflex, asymmetry of abdominal reflex is more important than symmetry. You can see this patient had an intraspinal anomaly having an asymmetrical abdominal reflex. Superficial reflexes, these ones are uncommonly done. Cremasteric reflex is L1, L2. Anal reflex is usually done in spinal cord injury patients. Power examination, remember the root values. There is no way of getting out of it, and it is graded by MRC grading. The thing to remember about MRC grading is that uh, for the grade 1s and grade 3, you can reproduce, right? You can sometimes easily tell the difference between grade 1 and grade 3, but grade 4 and variations of grade 4 are very difficult to kind of have an inter-observer reliability, because grade 4 plus, grade 4 minus, so there are so many variations when it comes to the more just suboptimal muscle strength. But the very severe weakness is the MRC grading is more useful in categorizing. Coordination, heel to shin test and finger nose test, will not go into that for want of time. Sensory examination, remember the sensory modalities with respect to the columns that are transmitting these modalities, because the pain and temperature will cross at the spinal cord level, ascend the spinothalamic tract and go up. So the lesions of the spinal cord will affect the pain sensations accordingly. Proprioception and joint position sense will ascend on the same side in the posterior column. It will cross at the decussation at the brainstem, medial lemniscus, and then go to the brain. For light touch, will go from both sides, posterior column as well as the anterior spinothalamic tracts, ventral tracts. So it has both kind of mechanisms of going up. So go ahead. And then comes to these dermatome patterns. The thing you want to remember is that these dermatome patterns are just for some judgment. These netter diagrams are very pretty, and they are absolute in terms of the drawings, but the dermatomes are never absolute. So you cannot go that, okay, this part has to be L5 or the middle finger is always C7. It is not like this. Any nerve root in the brachial plexus can cause numbness in your middle finger, which we traditionally think, according to Netter's diagram, it will be a C7 dermatome, but it is not like that. There is a lot of overlap and mix and match. So you need to remember that when you are assessing sensory modalities. Assess light touch, pain bilaterally, explain it, go from normal to abnormal side. Joint position sense is assessed this way. Don't keep your fingers on the thumb like that, because you will give away the joint position by the pressure sensations the patient will feel. So you'll have to keep it on the side like that. Vibration sensations is typically tested in the most distal aspect of the extremity. If it is normal, then you don't do it further. If it is abnormal in the thumb or the toe, then you will go to the medial malleolus. If it's abnormal in the medial malleolus, then you will go to the tibial tuberosity. So you ascend proximal only if you have abnormalities distally. Rectal examination usually done for spinal cord injury patients or suspected cauda equina patients. Sensation, tone, sphincter contraction, anal reflex. But the tone and the voluntary anal contraction, abnormal ones, you will be able to judge only if you know what normal feels like. So one day go to the urology OPD, asks your friend to just ask them to show you what normal feels like. But because if you don't know what normal feels like, you won't be able to judge what abnormal feels like. So special tests would be decided on the basis of your symptoms. So you don't do everything for everyone. For lumbar radiculopathy, you have the SLR. You know this diagram very well, but it's important to remember that SLR is a sensitive test, which means that there are a lot of conditions that would give a passive SLR positive. You can make the SLR more specific by doing the forced dorsiflexion or the Bragard's maneuver, but in general, 40% specific. So the importance of SLR is in the negative test. So if you are suspecting somebody who has radicular pain and the SLR is negative, think twice before labeling that patient as a disc herniation or radiculitis patient. Cross SLR is well leg SLR, where you are doing on the normal side, patient is experiencing pain on the affected side. This is very specific test, but not as sensitive test. It's if it is there, it usually means an axillary disc or a very large central disc herniation. Bowstring sign, not very sensitive, unknown specificity. It's definitely lesser sensitive than passive SLR. So passive SLR is the gold standard test. This is not a commonly done test as a bowstring or the cram test. Slump test, again, more sensitive like SLR, but less specific like an SLR. It's almost like doing a sitting SLR. So the characteristics are very similar to an SLR test. You can do this for somebody who is you suspecting is malingering, is who is not giving you the right things, but you can do a slump test. It's like a distraction test, you may call it, because you are distracting the patient by just sitting and then asking the patient to straighten the leg. Um, Piriformis syndrome, if you are suspecting, you can do a Fair's test, which is a flexion, adduction, and internal rotation. And in this position, the piriformis muscle becomes tight and the sciatic nerves get compressed. You can get buttock pain or pain radiating down the leg, which the patient is complaining. Femoral stretch test you will do only if the patient is complaining of anterior thigh pain. Sensitivity is not as great as a passive SLR, but it is specific. So if it is positive, then you can say in general that the patient has an upper lumbar root involvement, but it is not positive in most patients because it is not sensitive enough. Cervical radiculopathy, you have Sperling's maneuver, again, low sensitivity, high specificity. You won't do this patient thing if you suspect instability or some other disease which is dangerous. Valsava is a provocative test. This is an easy test to do. Distraction is a relieving test, so you will do it only in the presence of radicular pain. You distract the neck and the patient feels better. Shoulder abduction sign or Bakodi sign is a very common test. Again, not very sensitive, but maybe specific. At this point in time, you might as well do a shoulder examination because you're abducting the shoulder, and a lot of arm pain could be coming from the shoulder as well. Some of the arm pains can be peripheral nerve root involvements like carpal tunnel syndrome. Remember where to press in the Durkan's test. It is proximal to the wrist crease like this. You can do a Durkan's test in the flexed position also. That means you're combining Fallon's and Durkan's, that you keep the wrist flexed and then press on the carpal tunnel and the patient's symptoms are reproduced. Thoracic outlet syndrome, quite difficult to diagnose. The reliability of these Adson test and Roos test is not so great, but once in a while you will be able to pick this up, but it's much harder to pick up thoracic outlet syndrome in general. Myelopathy signs, this is the finger escape sign. We all know Wartenberg sign, where patient is unable to keep the little finger abducted, adducted, it kind of abducts and flexes. This is the grip release and grasp. The release is shorter than the grasp, generally speaking. And you can see that the patient is doing some sort of a trick motion here. And the reason why they are doing this trick motion is because the IP joint can be extended, but the MP joint cannot be extended in cervical myelopathy who have these kind of features. And when they want to open their hand, they need to flex their wrist, because when they flex their wrist, the extensor tendons become tight and contracted, and then the fingers open. And for closing the fist, they have to flex the wrist. When they flex the wrist, the flexor tendons get kind of contracted and shortens, and that's why the fingers flex. So this is a differential. And in patients with motor neuron disease, it will be exactly the opposite. They won't be able to extend their IP joints. Their IP joints will remain kind of flexed whenever they try to release their hand. But here you can see the IP joints can be extended, but because they can't extend their MP joints, they're doing a trick motion at the wrist. Again, false localizing for myelopathy, remote atrophy in the hands. Sometimes myelopathy patients can have Lermite sign, but it's usually reverse Lermite, which means they get pain or electric sensations in extension position rather than flexion. Ankylosing spondylitis, cervical mobility, occiput to wall distance, chest mobility, chest expansion, and lumbar mobility is the modified Schober's test. These are tests done to measure range of motion in a serial fashion. Abnormal Schober's test would be if it doesn't increase by at least 5 or 6 centimeters. Other joints do a hip, knee, SI joint examination. Faber's test is a quick screening test, but it's not a very accurate test to rule out sacroiliac pathology. That's the Ganslan's test. Remember, the leg that is being flexed is not being tested. The one that is being extended is the side that is being tested. That's the Ganslan's test. Vascular, remember, most patients are elderly patients who come to you with canal stenosis and vascular claudication. Remember to touch their feet, take their Ashirvad. Remember to always check for pulses in patients who have claudicatory symptoms. Cutaneous changes with peripheral vascular disease are important to judge because you may have still palpable pulses in patients who present with peripheral vascular disease. This is varicose veins. And then do a general examination. We'll quickly run through general examination. You need to know the pubertal stages because the sexual maturity and the growth are related in terms of spinal deformity patients. This is pectus carinatum, Klippel-Feil syndrome. This is a Marfan syndrome with arachnodactyly. You can see very long fingers, high arch palate, very long arm spans, hyperactivity. Sorry, I'm done. This is the
Yeah.
signs of um, intradural problems like split cord malformation. This is neurofibromatosis, limb-length discrepancy. Left side foot is smaller than the right side foot. This patient had diastometamylia. This patient, you can see, has cavus foot and some sort of dimpling there on the back, very faint, but then has a tethered cord on the MRI. You can see that tethered cord here. Thank you very much. I'm done. All
Yeah,
right.
thank you. Sticking to time. You really covered almost everything.
So
So,
we can take maybe questions for 5 minutes and then we'll move on.
yeah, please. Any questions for Kshitij? Please go ahead. Anyone wants to ask anything?
So yeah. So it's I think one link to the recording. The recording will be on Ortho TV. So I think you can see that on Ortho TV. But yeah, scoliosis examination would be a lot focused on the alignment and the posture of the patient because you are actually describing a deformity. So the initial part of inspection and palpation would be the description of your deformity. So the way to think about scoliosis is look at the spinal alignment in 3 dimensions. That means coronal plane, sagittal plane, and the axial plane. Look at that's the alignment, and then understand what is the alignment doing to the posture, because the bad alignment of the spine would affect the posture in terms of head is not centered over the pelvis, shoulders are not level, the ribs are unequal, there is a flank crease, arms are not symmetrical on the side, pelvis is oblique, rib one side is prominent, all those sort of left to right asymmetries that you see in coronal plane and in sagittal plane, hypokyphosis, hyperkyphosis, leaning forward, all those sort of things. And in Adams forward bending test, you can have rotational deformities. And so scoliosis descriptions, think of it as spinal alignment and how does spinal alignment affect posture. Please explain level of localization with respect to alpha motor neuron. So the way to remember is that first remember that the spinal cord is shorter than the spine. In cervical spine, it is not as much shorter as it would be in the thoracic spine. So at C4, C5 disc level, you have the C6 alpha motor neuron. Okay, one level below. So C4, C5 has C6. C5, C6 has C7. So one shorter. So if you have a C4, C5 disc, then C6 alpha motor neuron is at the disc level. So if you have a large central disc herniation compressing the spinal cord, it will be lower motor neuron at C6 and upper motor neuron for C7, C8, T1. C6 reflex is the biceps reflex that will be absent. C7 reflex is triceps reflex. C8, T1 is Hoffman's Tromner's. Those will be exaggerated. So this lesion, this sort of pattern will localize to the C4, C5 disc level. So remember that you can have an absent biceps reflex both at the C4, C5 disc level as well as the C5, C6 disc level. At C5, C6 disc level, if you have a paracentral disc herniation, that means a foraminal disc herniation that is causing a root compression, because C5, C6 has C6 nerve root. So if it's a root compression, you will have an absent biceps reflex. If that disc herniation is large enough to cause C6 root as well as a spinal cord compression at C5, C6, then at C5, C6, alpha motor neuron is C7. That means the patient will have an absent biceps reflex, an absent triceps reflex, but a exaggerated Hoffman's and Tromner's reflex. So a large C5, C6 disc that is involving the spinal cord as well as the root will cause a lower motor neuron. C6 will cause the alpha motor neuron involvement of C7, both biceps, triceps absent, but Hoffman's, Tromner's finger jerk will be exaggerated. So the kind of the spinal cord and root is the way you are thinking of how the reflexes would go. Is there a grading system for hand grip like MRC grading? No. Hand grip is the way to grade hand grip is by using a dynamometer. So you have these dynamometers, you can keep those dynamometers in your OPD. Each dynamometer is calibrated in a particular way. So if you are using like say a dynamometer, multiple dynamometers, you won't be able to compare. You can compare only one because it is calibrated that way. But the best way to judge is by checking left and right. For a dominant right-handed person, generally the dynamometer readings will be sort of 10% difference normally. If anything more than 10% is there, then that's abnormal. And it's a good tool to have. Sometimes you can pick up very subtle weaknesses in hand grip with dynamometers. So that's about the hand grip. And then what is the next question? During finishing, one should say details about gait, antalgic gait, about abnormal window progression. No. You don't have to describe all these things. You just think if the gait falls in a particular pattern, say that the patient's pattern is this. If you can't understand the pattern or it's a mixed pattern, then you can describe the pattern that the patient is having whatever arm swings, antalgic gait, short stride, and that way. If it's kind of a mixed thing, then you can describe the gait if it's a mixed thing. But generally, you will be able to, if somebody has a myelopathic gait, say it is a myelopathic gait. And then the examiner, if they ask you what is the myelopathic gait, why are you saying it's a myelopathic gait? Then you describe the gait. The idea in your fellowship exam is for the examiner to assess what is your thought process behind your case. You need to reach the imaging, the treatment plan and everything in a fellowship exam. You are not giving an MS exam or a resident level exam where we don't expect those guys to go and do spine surgeries. But fellowship is a different exam. So you don't want to get trapped in, the history and the examination. You want to convey your findings. If they want to ask you and stop you, fine. If they don't want that and they want to discuss the case with you, you just have to be confident in saying things. When you are confident, they will not interrupt you, especially if they agree with you that the patient has myelopathic gait or antalgic gait or Trendelenburg's gait or whatever. Right? I think we'll move. It's we are right on time at
Yeah,
9.
yeah.
So then I'll invite the next speaker, Dr. Ayush.
Yeah.
He's going to, you can share your screen.
Yeah,
He's
yeah,
going
Kshitij.
to help us read lumbar spine X-rays, a very important topic. So go
So,
ahead.
yeah. So, thank you, Kshitij. I think my screen is visible. I am audible. Can you see my screen, Kshitij? And I hope I am audible.
Yes, we can see your screen and you're audible. Yes.
Okay, okay. So, I will be talking about very basics of lumbar spine X-ray. Okay. So, this is how I see a X-ray. It is the most basic and most informative and a very, very unique investigation. The problem with today is if you see most of the patient, at least those who come to me, they always come with a MRI, and at least 30 to 40% of them are missing a basic spine X-ray. And that is a big problem because although MRI gives you a diagnosis of the pathology, and it basically talks about you looking at the soft tissue and all the root or the dura, but it is the alignment which is equally important, or I will say more important than just the vision of a MRI. So this is how I look at it, X-ray. This is a mirror image. This is the X-ray of a patient, and this is a C-arm image of the same patient. And if you see them, they are like a mirror image. For a spine surgeon, X-ray means much more to me, especially for someone like me who is a MIS, minimally invasive spine surgeon. This is how I see the patient when I'm operating it, and this is how the X-ray allows me to see them. This is what you normally see in a X-ray. This is standard X-ray lumbar sacral spine. But this is what I see. Every patient which I see in my OPD, not only I see this, but I see something more to it. And these are the small things I'll try to tell you over the period of time. So, you need to have a vision which goes beyond the normal X-ray. And if you know the normal, you will easily be able to pick the abnormal, and that is what you want to do as a specialist or as a surgeon. This picture perfectly describes why it is important to have both AP and lateral view. But in spine, we do have some unique views. You can have a oblique view when you rotate the patient 35 to 45 degree, and this is the famous the Scottish dog appearance which you see, where if you see a break in the neck or the collar of the dog, which is sort of represents the break in the parts, and that is what you can see. There are few more oblique views which can be taken, but I'll just stick to the very basic because of the time limit. Serial X-rays are again very, very important. It tells you about the prognosis of things, and this is the one of the very simple and very basic way to look at the prognosis of a pathology or a deformity, as you can see here. A dynamic view is again a very, very unique and very, very important view. This is a classical flexion extension view, and because this is the only way you can do it, this is the only way you can check the dynamic, until unless, of course, now you have a dynamic MRI. So, but not everyone has a preview to a dynamic MRI. So this is what a dynamic MRI represents. It sort of tells you when is the compression happening. But even if you don't have a dynamic MRI, you can sort of extrapolate it, understand all your investigation, whether it's a X-ray or a MRI or a CT scan. They are all done in supine position. So they are not like having any dynamic component to it until unless you sort of order for a dynamic MRI. Why most of us doesn't have a dynamic view, but you have a dynamic X-ray. All you need to do is extrapolate the dynamic X-ray to look at the pathology and probable culprits. It is, for me, it is very, very important, especially when I'm looking at the cervical myelopathy cases. I do extrapolate those X-ray images and collaborate with my MRI images to see if there is any dynamic component to it. Again, lateral bending films are another unique films. They let you decide and let you judge the pathology. They let you judge the treatment protocols. And this is what you can see here is a right lateral bending film. And you can see from the images, the lumbar spine in this case is sort of flexible, and it tells you what type of curve it is, what type of surgery you want to do. So this is what was done for this particular case. Again, as I was telling you earlier, all your investigation, most important investigation, the CT and the MRI, they're on in supine. A standing X-ray is of paramount importance. What you can see, this is a standing X-ray where you can see the collapse of the vertebra, and this is a supine MRI. This just tells you that there is a dynamic component to it, and if you leave this structure just like that without doing anything, then most likely there is a chance that either it will be fused in this position or it can go even further. The standing X-ray is again a unique feature of the X-ray. Most of us don't have access to a standing MRI or a standing CT. So it is a only weight-bearing investigation, and all you need to do is collaborate with the other investigation to get an idea about it. This is again very, very important. I'll suggest all of you or most of you should have access to a full-length X-ray. It tells you a lot of information. Just a simple lumbar spine X-ray is good, but if you really want to understand the pathology of the spine, you should always insist for a full-length X-ray. Now, if you look at this X-ray, it tells you that the bulk of the problem is coming from here, and it's leading to a significant pathology and significant SVA. So you need to get the best out of that level, and that is what it tells you. Now, again, look at these images. You see, this is a high-grade listhesis, but this is a balanced spine. The balanced spine, and these are some of the images you can see we have drawn. I cannot go into detail of it, but I expect you to understand what is the pelvic balance, how to measure this, how to understand this standing MRIs. And I think Kshitij has a video somewhere where you can go through and understand how to understand these points or understand this line. So this is a balanced spine. So all we have done in the high-grade listhesis is to do a in situ fusion. But look at this. This was an unbalanced spine. So all we have got a complete reduction in this case. And this is the final standing X-ray and final measurement showing that this spine is completely balanced. So these are important things which you can get from a standing full screen X-rays. Again, going into if you further go into it, they tell you a lot of information. Not only they tell you where is the pathology coming from, and where is the problem coming from. It also helps you sort of decide your treatment pathology, how much you want to get out of each level, and how to go about it. So basically, these X-ray not only help you diagnose the problem, but it also helps you plan your strategy. And this, although MRI and CT scans are there, but this is the only thing which will represent the walking style or the standing style of the patient. And that's why I will suggest each and every one of you should always try to get a standing full length X-ray of a patient. Again, these are other things which you can see here. Again, if you see these, not only that they give you about information alignment, if you have a careful, if you look at X-ray carefully, it also gives you a lot of information about other pathology. You see here, the edges of this pedicle is not clearly visible. The reason being, this is CT scan of the same patient, and you see there's a infection which is sort of hugging to that pedicle, and as most of you know, this is called winking owl sign, and this is not only specific to infection, it can be also be seen in any tumor. As you can see here, this is the same sign, but in a case of a tumor. But in tumor, as you can see, there is a ballooning out effect on the pathology, and there's a lysis of that pedicle. So, you all you need to understand is, if you have been looking at the normal X-rays, it will be very, very easy to pick up the abnormal X-ray. So you need to keep looking at all your X-rays of all the patients which comes to your clinic. Osteoporosis is a bit difficult to diagnose with X-ray. It has to be 30 to 40% of the bone involvement when you can see it. But if you see, this looks like a host vertebra, means you have the vertebra has lost its cortical and tabular pattern, and that is when you can see osteoporosis. Or if there is a compression fracture, you can diagnose osteoporosis. So for me, this is how I look at each and every X-ray which comes to me, and that gives me an idea how is the pedicle, how it will look on the imaging. It also, I have drawn few lines. It also tells me if I will be able to approach these levels, including some specific techniques. Like example, the iliac crest determines my the transfemoral approach to spine. So sort of, if you see this is L4-5. I can use the transfemoral approach for this level, but if I have to use the same thing for this level, it could be slightly challenging. So it gives me unique vision and helps me plan my strategy. This is what I see. Again, when I see at a lateral view, I look at the foramen, I look at the disc height, I even look where the rib is. All these things helps me plan my cases, because this is how, if the patient is with a degenerated spine, the nerve root will be down, and all the access to this in one of my surgical approach will be very, very compromised. While here, it is much more easy to do the job. Again, if you see this rib here is coming into picture, and if I have to do a transfemoral approach to this level, it's sort of, I need to negate that rib head. So these are very unique information which comes just looking at a simple X-ray. A follow-up X-ray is again of paramount important. Not only use X-rays to sort of, plan the surgery, to diagnose a pathology, but it is one of the basic things and the most important, the normal thing which you do for each and every case which you have operated. So if you see this case, you can get a good idea about how your implant position is. How, if you can, this 2-year follow-up shows a very, very good bony fusion. Not only it tells you about the good things you have done, it also shows you if anything has gone wrong. You can see this patient came after 6 years and in a routine OPD, but if you see the cage has gone almost posteriorly. So it is one of the easiest tool and one of the quickest tool to pick the pathology. And if you see carefully, a simple X-ray will tell you a lot of things. This is a 8-year follow-up of the same patient. And if you look at the disc height, you can see there is a ASD happening, and it sort of tells you how the pathology is going, how the problem is advancing. And it is like, so for me, X-ray is just like a mirror, it just like the mirror which sort of gives you a basic information about yourself, and which never lies. The X-ray never lies. It tells you your good work, it tells you what bad you have done, and it tells you the ugly things which has happened, like the ASD in this case. So at the end, and keeping with the time, I'll just say a normal simple X-ray is something which you should always ask for. It is something which has more to it. It's just not about it's not just a simple image which you don't need to care about. So that is all from my side, Kshitij. Thank you.
Thank you, Ayush. Wonderful talk and amazing surgeries. So we can take questions for Ayush. I'll look at the chat box while people are using the chat box. So let me ask, what are in OPD, what are your indications for doing an X-ray for the usual back pain patient? That would be like 80% of our OPD is sort of like that. So
So,
when
so
would you kind of get an X-ray?
So basically, see, it totally depends. See, if back pain is as you know, it's a Pandora's box. Okay, it can come from anything and everything. So, but if you really, there are few specific things, like if anything which sort of tells you if there is a problem with, like, there's some sort of instability is happening, or maybe like if the patient tells while he's having a extensive back pain when he's stressing his spine, definitely you like to have X-ray. Again, simple things like patient has some sort of a trauma or something and comes with a significant back problem, definitely you like to have a X-ray. Again, in examination, there is something which suggests there is a severe spasm or something, and maybe with a radiculopathy, maybe you like to X-ray just to see if the disc is degenerating or something is happening. So no, but it is something which, as you rightly told, it is like a Sherlock Holmes job. You need to have a very good clinical examination, and that should lead you somewhere. And the X-ray is just a supportive diagnosis which sort of helps you confirm what you are suspecting. It doesn't mean that you need to have X-ray for each and every patient.
So I think I'm not seeing any more questions for you. So if there are any more questions for Dr. Ayush, you can put it in the chat box and he's available and he'll be able to answer in the chat box. So I'll invite the next speaker, Dr.
Kshitij, Uday Pawar is running late. So
Okay,
Abhilash is the next. Yeah.
Abhilash. Okay. So it's a little bit sequence alteration because after X-rays you would think of MRIs. But let's imagine that MRI is already done and then we are looking at PET CTs and when to do it and how to interpret by Dr. Abhilash Dhruv. Abhilash, you can share your.
Yes, yes, I shall do that in a bit. All right, can everyone see my screen?
Yes.
Perfect.
We can hear you loud and clear.
Yes. I'm sorry, I'm on a vacation right now, so you might hear some kids screaming in the background. I'm sorry. Yeah, okay. So guys, my talk for the evening is an FDG PET scan, what a spine surgeon needs to know. So for starters, we need to know what an FDG PET means. An FDG is a fluorodeoxyglucose positron emission tomography scan. Now, what exactly is what I just said? Let me just put that into perspective in the consequent couple of slides. So we go back to some basic physics and biochemistry, which we've all learned. We all know the metabolic activities of tissues will require glucose. Glucose is taken up by the tissues. It is converted by biochemical processes into ATP. ATP is the energy currency of cell. This entire process is manipulated by researchers and scientists, wherein they have had a radio-labeled nuclear isotope of glucose, which is called an 18-fluorodeoxyglucose. What happens is it competes with the glucose already present in the blood and is taken up by the cells. Now, what is important about an 18-FDG? This is an isomer. It decays. It sets out positively charged particles called positrons. So the moment it enters the cell, the positron is released. Now for the isotope to stabilize, this positron has to be negated. A positive particle interacts with the negative particle, which is an electron. Now, positive matter, negative matter interact and they cancel each other. This cancellation reaction is called annihilation reaction. When that happens, there is an emission of gamma rays. All remember Hulk from all your Marvel movies, gamma radiation. Now, these gamma rays basically are emitted in roughly 180 degrees, that is opposite to each other. These rays which are emitted are then detected by, let's say, a detector by a process called as coincidence imaging, wherein a gamma ray hits the detector at 180 degrees to it. The detector detects another gamma ray which is hitting the detector within a specified time interval for it to be coming out from the same particular region. Now that you know how the fluorodeoxyglucose interacts in the cell, we have two situations. Cells which have higher metabolic activity will require higher glucose. So in this case, a higher amount of the radioisomer is taken up and consequently higher gamma ray is emitted. Vice versa, a cell with low metabolic activity, going by the same algorithm, will emit less of gamma rays. This is the basic principle of a PET scan. So when you order a PET scan, you figure out tissues which are metabolically active. Does it give you an idea as to which tissue is exactly active? No. For that, what do we have? We have a CT scan. CT scan is excellent for structural localization of pathology. So now you can understand there's a functional imaging, which is a PET scan, where you figure out tissues which have high metabolic activity, and you have a CT scan which tells you where these tissues are located. Software fuses the two, and what we have is a PET CT scan. Before we go into the applications of a PET CT in spine, we should know the normal distribution of this radioisomer in spine. So as there is a physiologically increased uptake at the level of T11 and T12, slightly lesser degree uptake at C4 and some uptake at C1. Now there are many theories to this, none of them is proven, but the theory for increased uptake in the lower thoracic spine is supposed to be the inadequate clearance of the tracer from the artery of Adam Kiewicz, which we all know. And the second is a slightly higher cross-sectional area of the spinal cord at the mid-cervical and lower thoracic levels, and also an increased amount of gray matter. Gray matter is neurons. Neurons are the ones which are metabolically active. So now you know the normal distribution of spine. So as a spine surgeon, when do we require a PET CT scan? The most commonest indication that all of us will talk about will be in cases of tumors, as in cases of metastasis. So a PET CT is considered to be the best modality to pick up bony metastasis because we are only limiting ourselves to spine. It is the earliest detection because in cases where you know where a primary tumor is, if you do a FDG PET scan, it'll pick up the metabolically active tissues in your spine before the MRI picks them up. The good thing is even lytic and blastic mets irrespectively will light up on your PET CT. When we are treating this patient, when we have to monitor response to the therapy, it still has its own shortcomings. For that, there is increasing research going on about PET MR. Now, in conjunction with bony mets, even epidural and intramedullary mets are picked up by this particular scan. So, we order a PET CT, we see numerous levels lighting up. Does it mean all of them are mets? No. In primary osseous lesions, like let's say multiple myeloma, you will still have lesions which are metabolically lighting up. So what does it tell you? A PET CT is not the be all and end all. It is always to be used in conjunction with the existing modalities that we have. Another example would be a hemangioma. A hemangioma which has a recent hemorrhage will show increased inflammation, will also light up. Otherwise, hemangiomas are all a photopenic, wherein the particular level is not going to light up on a PET-CT scan. In cases of neoplasms, when you're monitoring all your tumors, PET-CT has an excellent post-therapy changes. Now, two important situations. Patients undergoing chemotherapy will usually be leukopenic. We give them GCSF, that is granulocyte colony stimulating factor, or the other modality will be radiation. Now, both these therapies cause increased marrow activity. So, both of them are going to light up on a PET-CT. So usually, see, not that we are going to order that, but this is what your radiologist is going to be telling you. Oh, this is lit up. It doesn't mean that all of them are active meds. It's important to remember your PET-CT should be usually ordered around 3 months after radiation or GCSF therapy. As I mentioned, the lesions will gradually become photopenic once the initial changes of radiation and chemotherapy are done. That means your metastasis is responding to whatever treatment has been given. Here you can see a patient with multiple meds. As you can see, a mix of lytic and blastic meds. Your PET-CT is showing, a PET scan is showing no metabolic activity. You fuse the two, wherein you are saying the entire structure is not metabolically active, which means the patient who was given radiation has shown good response to the metastatic disease. Now we come to the more common applications of a PET-CT in infections. Now, we all know the best modality or the earliest modality for picking up infection is MRI. But MRI is not without its own drawbacks. Now, in conditions where you have picked up early infection, you could also be dealing with early degeneration, or MRI might not be the best modality when you have metallic implants in place. It might show a lot of uh, attenuation. In such cases, a PET-CT is going to be superior to an MRI. Why? Because a PET-CT is going to show the entire lesion to be metabolically active. It is going to light up. As a consequence, it can help us delineate the extent of infection. At the same time, once you have instituted treatment, whether it be antibiotics, whether it be debridement followed by antibiotics, a PET-CT would be a good prognostic modality, wherein a reducing uptake along with the other clinico-pathologico-radiological parameters would be a good way of judging how your therapy is acting on that infection, how it is resolving or not resolving. Here, I'll give you a simple example. A patient underwent spinal fusion. 2 months after spinal fusion, patient still had severe pain. His radiological parameters were not very significant. Patient was treated conservatively. Patient still did not respond. He still kept on having pain. A PET-CT done later showed up a lighting up of the L5, L4, L5 area, which was suggestive of an infection. An MRI done then showed this particular change, as you can see here. Yeah, as you can see, this is progressive infection from the previous MRI. This is where your PET-CT is going to help you. Now, a very important distinguishing factor between infection and degeneration. As you all know, type 1 modic changes mimic infection. How? Because they are hypointense on T1 and hyperintense on T2. It simulates the MRI picture of early infection. Now, a PET-CT would be possibly the best way to judge whether you're dealing with infection or modic change, but not as standalone. It is always in conjunction with your clinical examination, your basic WBC, ESR, CRP, and an MRI. When we use all these in conjunction, this is where it helps us delineate whether we are dealing with infection or a modic change. A type 1 modic change will show no uptake in the disc as opposed to spondylodiscitis. Very high sensitivity and specificity in diagnosing spondylodiscitis. Why this change happens? Because modic changes are predominantly degenerative where the basic cells are fibroblasts, as opposed to infection where the main cells that we are dealing with are macrophages and granulocytes. They are all metabolically active. They release enzymes in what we call as a respiratory burst. So it all lights up on a PET CT scan. Important to note that a lesion which lights up on a PET CT where we have suspected infection, there's no way for you to distinguish between a tumor and a infection in such cases. There are no described characteristic patterns for this. Now, this patient had chronic back pain. This is how his T1 looked. It is hypointense lesion, hyperintense on T2, and a stir also showed it lighting up. Patient was treated empirically because there was no fusion, there was no collection here, there was no roll of a biopsy. It was attempted, but there was no biopsy that was found. The patient was treated on empirical antibiotics, did not get better, was taken in for a PET CT scan. As you can see, the basic area of the changes, the MRI changes, did not light up on the PET CT, which means we were not dealing with infection. The patient was in stage 1, that is type 1 modic change. A very, very relevant indication for a PET CT would be tuberculosis, not exactly for the diagnosis, but tuberculous lesions are metabolically active, so they light up. So it determines the activity of the lesion. I will explain how. It determines which active sites can be chosen for a biopsy because the diagnostic yield increases from the active sites of TB. In case you have TB of an inaccessible anatomic region, a PET CT, because it goes across the body, it will assess the disease extent and can detect occult distant foci, which may be more amenable for a biopsy. As I mentioned, active tuberculosis lesions will exhibit a high degree of FDG uptake. And as I already mentioned in the previous slide, there is no characteristic pattern to distinguish an infection from a neoplasm. You all remember the adage that you have to biopsy all infections and you culture all tumors. Remember this throughout. So in cases of tuberculosis, how do you assess whether the patient is healing or not? We all may not be ordering this, but we all will have one patient of TB spine who's followed up at a 6 months with an MRI. Now the MRI may or may not show resolving infection. Now signs of healing is a hypointense T1 becomes normal, moves towards normal intensity. A hyperintense T2 becomes hypointense, and there is reduction in abscesses. At 6 months, you may not always have these changes happening because we all know that radiological healing lags behind clinical healing in cases of tuberculosis. So then you have a common, your chest physician says you meet your chest physician, you meet your spine surgeon and ask him whether we can stop it or not. We are all confused because clinically the patient is better. Radiological parameters are all pointing towards a resolution of the disease. At 6 months, a 6-month AKT is done. Is there a way that we can figure out whether what we are seeing on your MRI, whether that correlates with healing? Yes. A PET CT will determine healing in cases where abscess and marrow edema will persist or not persist. Also, a patient who is on sensitive AKT, if he has sudden increase in deficit or sudden increase in pain, a PET CT can determine a reactivation in such lesions. Now, once you do a PET CT, once you have an MRI changes which show it could be query healing, query not healing, a PET CT which shows there is no activity in the lesions that are picked up on the MRI is a good pointer to discontinue/continue your AKT. Now, I would like to conclude this by giving you a brief of the entire talk that I have in a nutshell. A PET CT is useful in cases of detecting metastasis for malignancy. Important to distinguish between infection and modic type 1 changes. It can detect or monitor disease activity in infections, can help us whether our treatment is the infection and malignancy, whether it is responding to the treatment that we have instituted. But we have to remember that a PET CT remains an expensive investigation. It can never be a standalone investigation. It is always supplemented by good, precise clinical, pathological, and radiological correlation. When we have all three in place, use of a PET CT will increase the accuracy of diagnosis and prognosis. With this, I end my talk. Thank you so much.
Thank you, Abhilash, for a very comprehensive talk on PET CTs. We can have 2 minutes of questions for Abhilash, and you can put them in the chat box.
I'm just
I
trying
will
to
go with
get
the first question. So
just
can
one
you
sec. I'm just trying
differentiate?
to stop share. Yeah, okay. Yeah.
Yeah. Can you possibly differentiate on PET scans benign osteoporotic fractures from metastasis?
So, as it has been mentioned, a lot of these benign osteoporotic fractures may not light up on a PET CT scan. So that would be a good
Acute
indication. But as
fracture.
I mentioned,
An acute
yeah,
fracture.
an
An
acute fracture, that's
acute
what.
benign
So,
fracture.
yeah, so as I mentioned, for me to say a PET CT, whether I will use to distinguish between the two, it always has to be in conjunction with the existing modalities, because both of them, an acute fracture is going to show inflammation, it is going to light up. As I mentioned, just because a PET CT is lighting up doesn't mean it is tumor, doesn't mean it is infection on a standalone basis. We always have to correlate that with other parameters along with that.
Okay. Anybody has more questions? So the way to differentiate benign osteoporotic from metastatic fractures is to try to look at the SUV max. So SUV max uh, would be kind of a number they give for how much it is lighting up. Hello everyone. And uh, sorry, how much it is lighting up on the PET scan, and benign fractures would light up lesser in terms of amount than metastatic. And there is kind of a range. The sensitivity and specificity would increase beyond a certain SUV max. I think it is 4 or 6 or something like that. But something is like clearly 9 or 10, then you can more reasonably say that it is metastatic. Something it is like 2 or 3, then you are more confident of it being benign. 5 and 6 range is sort of somewhere in between.
Yeah, so
So
that's what I
with that,
mentioned, Kshitij. As a standalone, not a good, I mean, there's still not very,
I'm
very
talking
clear
about
criteria
standalone
as a
SUV
standalone.
measurements.
Yeah.
Like, you have a fracture on the pathological fracture, single level, nowhere else lesion, metastatic or benign. MRI is kind of not giving you sort of an answer. So in those situations, just
Yeah.
you can look up SUV max and try to see. That's one way. You can ask the nuclear medicine people also and kind of get that sort of a judgment from them. But we'll move on to the next speaker. I think Dr. Uday Pawar is with us. Is he? I thought I saw him. Um, Uday,
Yes, yes,
finish
yes.
mine. Uday,
I'm here. Yeah.
go ahead with your talk on MRIs. So I'll invite Uday to share his screen.
Kshitij, we have a couple of questions on the chat box.
Oh, we have. So
Yeah.
until Uday shares his screen, we can take questions from the chat box. He's going to speak on how to read MRI. So one question is, will lesions in multiple myeloma be hyperintense on PET? Answer is yes by Abhilash. So that's there. And then what is the role of PET CT in sealed off TB abscess, unresolving in a clinically recovered patient? I think he answered that question.
Yeah, so when you have an abscess that you see on the MRI, but your clinico-patho-radiological correlation says that probably is recovering, but your MRI still shows an abscess, you can order a PET CT. If that abscess does not light up, you can be reasonably assured that the TB has completely resolved.
All right, go ahead.
Am I audible? Yes.
Yeah, you can start. We can hear you. We can see
Yeah.
your screen.
Yeah. So I'll be talking about lumbar spine MRI for us spine surgeons. So this is going to be a talk based on a surgeon's perspective more than a radiologist perspective. So what all we should be seeing in a lumbar spine MRI for a patient. So As we all know that it definitely cannot replace a clinical examination, because it should corroborate your clinical examination. That goes without saying. So anybody who is just going to diagnose based on MRI can do most of it, but it should be corroborated with your clinical examination. And there are many instances where just looking at the MRI and diagnosing, we have been caught on a wrong footing. So as I see it, it's a process, right from our fellowship days, or just working with somebody, you keep on seeing MRIs day in and day out, be it in the OPD, be it in your surgeries, be it in follow-ups. So it's definitely a process by which all of us, every time we see an MRI, that those many repetitions happen, and those that's how the thing gets stuck in your mind. So every time, whether in OPD or even pre-operatively, when you're assisting someone or you're doing a surgery, have a MRI correlation to what you're finding intraoperatively during the surgery. Once the surgery is done, again go back and see the MRI and see whether you have found out exactly the same fragment or you have decompressed. It always going back and forth from the MRI to the intraoperative definitely helps. And being surgeons, it definitely helps to have an intraoperative live view of what you're seeing, whether it's been replicated or not on the MRI, and whether you have dealt with the pathology or not. And obviously have your radiology colleagues. So like all of these things, we really can't have the nitty-gritties of everything, we can't sort it out on our own, but so have your radiology friends, make good conversation with them. So briefly, we know there are T1, T2, and fat stir images, wherein you suppress the fat signal and see if any lesion lights up. So on your left hand side is a T1 image where the bone is little bit seen more brighter than the disc space. The CSF doesn't glow as much because it enhances fat. T2, you see CSF more bright, whereas in stir, actually the subcutaneous fat and everything is suppressed. So it's a fat suppressed image, one of the imaging which is stir. And then you have contrast imaging as well, where certain lesions light up. The radiologist will tell you this is a typical thing that most of us are taught. See the alignment of the spine, basically A, B, C, D, E. See the alignment of the spine, see the bony changes, see the cord or the canal, see if there are any degenerative changes and any other extra things. Apart from all these things, you should see around the spine, whole spine and everything. So as far as the alignment goes, all of us can pick up a listhesis in the left-sided image, a degenerative scoliosis. So basically any alignment related issue, high-grade listhesis, all this you can pick up on a lying down MRI as well. And also you should know about the transitional anatomy, especially sacralization, and especially if you're going to operate on the patient, you should be knowing about transitional anatomy, lumbarized and sacralized. Sacralized more than the lumbarized segment, because that might lead you to a wrong level surgery. So you should be knowing about these things. Regarding bone, the MRI is, as we all know, is very sensitive, and where it's useful is it can help us in delineate focal or diffuse pathologies. The most commoner being modic changes, which I guess Abhilash was talking about. And there we have type 1, type 2 and type 3 changes, wherein type 1 is you see a hypointense signal on a T1 image and that lights up on a T2 image, which typically is seen in all edematous condition or vascularized conditions. Wherever there is water or edema, it's been highlighted on a T1 image, and sometimes it correlates with the patient's back pain. Sometimes, not always. If at all of all these segments, a type 1 modic change would correlate with the kind of back pain that your patient might be having. Type 2 is a fatty marrow change which looks lit up in both T1 and T2. Whereas type 3, whereas there is significant sclerosis of the adjacent bone, you will see bone formation, and that kind of is seen as a dark signal in T1 and T2 both. So of concern for us, modic type 1 is where it's a little bit confusing. It might have back pain, you might confuse it with something else or an infection. Then you get these diffuse changes of Schmall's node, wherein the disc herniation happens intraosseously to the adjacent, through the end plate to the adjacent bones, and that can sometimes give rise to acute back pain, and you can correlate that with your patient. But you see these things in many multiple levels as well. But sometimes you can attribute an acute Schmalz node can present with a significant back pain, and if you see this thing on a T1 and T2 edematous changes of an acute Schmalz node, it might correlate with your patient. The second right hand side image, we all are we get very excited when we see an anterior shiny corner sign, which is typically seen in spondyloarthropathy patients. But when you speak to the radiologist, they will tell you that instead of counting just on the anterior shiny corner sign, it's the posterior superior corner or the posterior inferior corner, which is a little bit more pathognomonic of a spondyloarthropathy kind of a picture. So a shiny corner sign posteriorly does carry more weightage than an anterior shiny corner sign on an MRI imaging. We all have been through this because the MRI over investigates and it picks up infection more commonly, and we all have this debate between tuberculosis, whether it's pyogenic or tuberculosis. For the most part, you can differentiate, but I think it should be a histopathological and a culture diagnosis rather than just reading on the MRI. But roughly, you can make sense of a pyogenic discitis, wherein the disc space is affected more commonly. As we all know, tuberculosis spares the disc and it gets affected at the last instant. But disc sparing lesions, if you see multiple loculated abscess, subligamentous abscesses, it more falls towards the tuberculosis pattern rather than the pyogenic discitis. But as I said, it should be a culture-based diagnosis and a histopathological diagnosis more than an MRI diagnosis. Obviously, then the MRI picks up a localized metastatic or anywhere where you see image on your left hand side where there is ballooning out of the cortices, especially the posterior cortex. You should suspect metastasis by and large, or some malignancy in these patients, either primary or a metastatic spinal lesion. So an MRI definitely picks up that earlier. And in some cases of leukemia, where there is a diffuse change on a stir image as well as on a T1 image of the MRI scan, it tells you that it's a diffuse lesion, because normally on a T1 image you should see more fat on a T1 image, whereas on a fat suppressed image the fat signal should be suppressed on the stir image. But where you see more fat enhanced image, whereas on a T2 the fat is been replaced by something else, the red marrow and the fatty marrow. When the fatty marrow is being replaced by other cells, then you see such kind of a diffuse pattern in a T1. These things the radiologist will definitely tell. Most of the radiologists tell us about a diffuse leukemia-like pattern for this patient on the right side. And then the more common bread and butter, what's happening to the spinal canal, what's happening to the disc. And so the radiologists typically have a bulging disc, it's a diffuse bulge or asymmetric bulge, or if it's a focal problem. So we all know that if it's a symmetric bulge, if the annular tissue just extends beyond the apophysis of the vertebra, if it's more than 25% more onto one side, it's an asymmetric bulges. And then the common lesions of protrusion versus extrusion. The protrusion is somewhere where the diameter of the protruded fragment is less than that of the annular tear, and an extrusion is where the diameter of the extruded fragment is more than from the annular tear. Same pictorial assessment of this thing: a protrusion on the left side image, an extrusion, you can see it's inferiorly migrated and the diameter is more than from the annular tear, and a sequestrated fragment where there is no connection with the disc per se, parent disc per se. The fragment is like free floating in the spinal canal, then you call it a sequestrated fragment. And I'm sure all of us deal with this situations day in and day out. Most of the residents and the fellows, they have an issue with the location of the fragment. So this figure tells you more about the location and how you label the disc herniations, where the central is if the disc fragment is somewhere in between both the medial side of the facet joints, you label it as a centrally located disc herniation. If it's located between the medial margin of the facet and medial margin of the pedicle, that is a subarticular or the lateral recess fragment if there is a lesion there. And both these fragments, they typically compress on the traversing route. So if it's an L4-5, you're going to get lesions, you're going to get the symptoms of L5 root. And then the rest two are foraminal or extraforaminal, or if there is a extrusion and the fragment has migrated proximally, up migrated fragments, then you would get the exiting nerve root symptoms. So foraminal, we say when it's below the pedicle, medial and the lateral margin of the pedicle, that's a foraminal extrusion. And anything beyond that, it's an extraforaminal lesion. So importantly, get used to seeing the parasage images, because in a rush, most of the times we just see the central canal and the sides, and this obviously is a bigger fragment, but a small diffuse bulge which is there. Many times we kind of disregard it just in a haste and OPD, and you are more likely to miss a extraforaminal disc herniation. Happens to most of the orthopedic surgeons and some budding spine surgeons as well. So make sure that you see this parasage image both in the sagittal as well as the axial images, and see once you have a clinical dermatomal or myotomal listing of the patient, you try to correlate on the MRI that this guy has a right-sided L3 or L4 radiculopathy, so I should see the L4 or the exiting root in this patient. So make sure that you check the parasagittal images both, especially on the this thing, because sometimes not only the disc herniation, but you can see some facetal hypertrophy getting and jetting into the spinal canal, or the space available for the nerve root reduces. The other thing is, whenever you're going to, if at all you're going to operate this thing, see where your muscle planes are between the erector and the multifidus. So you kind of know the anatomy and know how much far lateral you have to go to approach this lesion if you're going to do a Wilsey approach or a paraspinal approach for this to operate on this patient. Similarly, see the psoas planes as well anteriorly where the vessels are. So you get a lot of surgical, try to get a lot of surgical information, and that happens by going to and forth from the MRI and correlating with intraoperatively, going back and forth on the MRI images and the intraoperative images. Canal compromises, different definitions have been done, but by and large, it's most of us typically eyeball it and see how much is the canal. Realistically, you can't really keep measuring. The radiologists do it for you to anywhere between less than 10 to 12 millimeter of a spinal canal. You can call it as a stenosis, but typically most of us have. This is the more commonly accepted definition between the radiology group, that you have a canal compromise when the anterior CSF, it's a normal patient, when the anterior CSF is not obliterated. You can see it, you can call it as mild when it's mildly obliterated, but you can see the nerve roots properly inside the spinal canal. Moderately, you can see some of them are aggregated together, and when almost all of them are clumped together, you know that it's a severe compression, maybe from anterior and posterior. But this is the most commonly accepted definition amongst the radiologists, at least.
Uday, we'll be running out of time.
Yes, within 3-4 slides. So spinal cord tumors is one which you can get, and obviously disc degeneration and facet degeneration. Make sure you have, everybody knows this is a full facet sign on a lying down MRI. You know that there is a hidden instability in this thing, so you got to address that as well. Importantly, post-op imaging is where MRI definitely helps us, and most of us know that it helps us differentiate between a post-operative scar or a post-operative disc herniation, when you need to get a contrast MRI. And if it's a enhancement periphery, you know that this is a recurrent disc herniation, as against which is evenly lighting up on a contrast MRI, you know that's a scar tissue. Obviously, MRI also helps us guiding, whether telling us whether it's these three main issues of hematoma, infection, or whether it's CSF post-operatively. CSF you can delineate. Sometimes you get an issue between hematoma versus early onset of infection, and the MRI definitely helps us point in that direction. But remember, this is oversensitive. You should always know clinically, and you should also know that most of asymptomatic patients also might show some degenerative pathologies, and don't label them and diagnose them based only on the MRI. And as I said, it cannot replace your clinical examination, and it's always a process of surgeons getting used to seeing and reading their own MRIs with the help of your radiology friends. Thank you.
Thank you, Uday, for a very comprehensive talk. I think we'll move to the next talk and then come back with questions for both Uday and Manish. We can do that together. So I'll invite Dr. Manish Kothari to share his screen, and he's going to speak to us about electrophysiological tests for assessing neurological functions, how to interpret it. Manish, you can share your screen. And in the meantime, if there are questions for Dr. Uday, you can put them in the chat box. We'll take them live once Dr. Manish has finished. So Manish, can you share your screen? So while Manish comes up on the screen, we can take questions for Uday for MRI. Maybe, oh, Manish has started. Okay. All right.
I'll keep it very brief. So nerve conduction is basically what you need to understand is that it's an extension of your clinical examination. It is not a magic or a blanket test which will give you your diagnosis. Nerve conduction, EMG, NCV is an extension of your clinical examination where you have a working diagnosis, provisional diagnosis, and you want to either confirm or rule out certain other conditions. So that's the most important part. Now, nerve conduction always works with the hypothesis of finding the pathology and what is the pathology. So there are various findings that will come in the form of whether it's in the form of axon or the myelin or the sensory nerve or the anterior horn cell or a central nervous system pathology. Some of them will be neuromuscular also, but that's not our general interest, like myasthenia gravis. So, what are the goals of a diagnostic study? Is one, as I said, one is to localize, other is to find the severity also. In localization, it's you have to group them into either muscles, nerves, or the neuromuscular junction. And the fourth one, as I said, it could be a central nervous system pathology. So we need not go into the details of too much of this. This is a very extensive topic by itself. What you need to know is when to order and how to interpret the findings. Generally, you send it to your neurologic colleague and they will do some tests and they will give you some of their findings. But how to make sense of it becomes your job. Most important is also kind of writing a note to your neurologist that what are you suspecting and what you are looking for with a very brief history also you need to give. Also, you need to send it to a neurologist who will take a history and kind of also maybe examine the patient, not just do the test by the technician and then give a signed report by the neurologist. So that may actually put you in more trouble than sort out your problems. So in when you are localizing, as we said, it could be in the nerve, it could be in the axon, um, it could be in the myelin, it could be in the plexus as a whole, or it could be a mononeuropathy. It could be a multiple mononeuropathies, as you can see in diabetes, and it could be a polyneuropathy. Myopathic, we know we are not interested in myopathic per se, and NM junction again becomes the myasthenia groups. So, what are the basic? We are going to look only at the basic tests that we do. The first one generally to be done is the motor conduction studies. It is performed first. Basically, you put in your stimulator, and there are two nodes. One is in the belly, and one is in the tendon. And then you measure the distance, and you see at the nerve conduction velocity. So you have a fixed distance, and you have a fixed timing, and then you calculate the velocity of the nerve conduction of that particular nerve. That is a motor action potential is generally biphasic. In this, you also look at the latency, you look at the amplitude, and you look at the curve of the amplitude of the action potential. Is it biphasic, triphasic, or is it diminished? Second is the sensory nerve conduction. So in this, it tests only the sensory as compared to a motor. When motor, you are looking at the nerve conduction across the motor nerve and also the NM junction and also the muscle. So three components are being checked. In a sensory conduction, you are only looking at the sensory part. You are not seeing anything in preganglionic part. Only thing that you are seeing is the postganglionic part. So typically you will record the sural nerve, median nerve, and so on. And we need not go into the voltage and details of this. So these are the sensory nerve action potential. They are biphasic and triphasic depending on the nerve. Uh, next is your F response. The F response will test your entire circuit. It gives kind of a general outline of that one particular nerve, and it generally is more responsible, more findings in demyelinating polyradiculopathies. So why this is important? Because we commonly come across scenarios where patient comes with painful demyelinating polyneuropathy, which will mimic as a lumbar disc. MRI being MRI will find an asymptomatic disc and you will confuse it as a disc herniation and probably see whether the deficit is coming from the disc. But if you are in doubt, if your clinical examination is not matching the MRI report or the MRI level, then you should be looking at these kind of pathologies. The other one is your the response is that it will only check for that one particular nerve. It will not check all of them together. When we are looking at the radiculopathies, so when you are looking at the radiculopathies, your F response can be positive, but it is not very specific. Then going on to the H reflex is not very useful per se. It is just testing your ankle reflex. It is a reflex arc, sensory efferent and the local level neural arc in the spinal cord, and followed by the motor efferent level. It basically is specific for L5S1 radiculopathy per se, but any other pathology which is affecting the ankle reflex will also be absent. So it is not a very specific test, but in a clinical scenario with other findings coming, then it kind of your H reflex kind of makes sense. Then next comes is the spontaneous activity, is the basically the EMGs. So EMGs, you look at two things. One is when you put the needle inside, and when you put the needle inside, there is a resting membrane action potential. That is a baseline activity. And then you insert, there is a spike of motor activity. So that is called as insertional activity. So all of these you interpret in various pathologies. And according to your condition, you will get like a kind of a diagnosis. So typical scenarios being, say, you are looking at a L5S1 radiculopathy. You need to understand that all these nerve conductions test a mixed nerve or a kind of group of nerves, roots. So generally L2, L3, L4 is considered as one root, as a one test. You cannot differentiate between L2 and L3 nerve root pathology, but it will generally be given as a L2, L3, L4, and L5, S1 is clubbed together. So if you are looking at, say, why you need to know all these things, that because what to expect from the report is important. You cannot expect is a specific L5 root pathology or a specific S1 root pathology. You will always get L5, S1 or L2, L3, L4. Same for cervical, the roots are clubbed together, but cervical is generally more specific because you have more roots and more muscles to define. In lumbar spine, that's not the case. So I think I just will cover the basics with this. We can take some questions if we have any. Hello?
Yeah. Hi. Hello.
Yeah.
Manish, thank you very much. It was a very comprehensive talk, but it's a very difficult topic to understand if you don't understand the basic part of EMG NCV. So I
Yeah.
want to ask you a question. How how much operator dependent is this? Like when you in
Absolutely. So
practice, are you um, using it blindly that the patient goes anywhere or something specific
no,
you
no,
want?
as I said first, is that patient, you have to kind of find a neurologist who takes a proper history and is very anal about the technical part of it, because a few millimeters here and there will change the report completely. So it is completely operator dependent, and I specifically send it at my center only, where I know that there are consistent reports and I can speak to the technician as well as the doctor, neurologist both. So don't send it blanket to anyone. Find a person who gives consistent reports, known in that area. Commonly, what you see in the smaller centers, the technician will just come and do the report, and the neurologist will just sign it. So that doesn't work like that. You have to send it to a proper center and someone who's interested in doing these tests. As I said, few millimeters of keeping the needles here and there and keeping your stimulator distances, your whole velocity will change and the report will change. So,
Right, right. So, like when you already have an EMG NCV report with you, like from an outside center, how do you, like, say if you are dealing with a lumbar radiculopathy and you are not sure, and there is already an EMG NCV report from outside,
yeah.
can you tell us if we can make out whether this thing is done properly or not, or there is no way to know that?
So yeah, I don't look, I don't ask for nerve conductions for radiculopathies generally, unless my MRI and my clinical examination don't match. Then I'm looking at a nerve
Which,
conduction
what
test.
I'm saying is it's already done. Somebody's come to you with that report, and you have some doubt about the diagnosis, whereas the electrophysiology says that it is a lumbar radiculopathy.
Uh, as in, no, I don't, I'm not aware of anything of that sort. So,
So what I'm saying is that how do you rely on an outside report? Is this
no,
adequate enough or
I ask for a
not
repeat
sufficient?
test from my trusted person, or I don't ask for it at all.
Okay.
That way.
So you wouldn't believe a report from outside, is what you're saying.
If I am in doubt regarding the diagnosis and the report is not matching, then you either kind of wait and watch, allow the pathology to evolve, give it another 2 or 3 weeks, and then redo the test again. So sometimes you do the test too early, say, and the nerve conductions may not show anything. It may come out as normal. So you kind of need to wait for the pathology to evolve. The demyelination also takes some time to show on the nerve conduction. It won't come up very quickly.
Right, right, right. Does anybody have questions for Manish and Uday? I think we are nearing the end. We
Yeah,
are
we are,
exactly
most people have
10:30.
left also.
We are exactly 10:30, and I would like to thank all the speakers for taking the effort to prepare all these talks. I mean, including me, I already had a ready-made talks, but I can imagine EMG NCV is not a really easy talk to prepare. But thank you very much, Manish, Uday,
Thank
Abhilash,
you.
and Ayush. The next session is going to be on 11th April, and that is going to be on lumbar canal stenosis. So make sure you join on 11th. That is going to be an interesting session. This entire series, monthly webinars for fellows teaching, is sponsored by Intas, and we are grateful for OrthoTV for hosting us. Until next time, thank you very much.
Thank you. Good night.